Hello, I'm Dr. Kim Yong-jin. I'm with Ilsan Dental Office. Today is the last lecture of OneGuide series lectures. I will talk about how to apply digital guided surgery in complex cases, such as in complete edentulous or multi-teeth missing cases, full mouth implant cases, or multi-teeth missing cases are where this is needed. Sometimes the placement cannot go as planned, and in the upper anterior, implant tilting can occur. How can we do the troubleshooting for such cases? So this is what we are going to talk about in this last lecture. If you look at these cases, this is where the guided surgery is most needed. In completely edentulous patient, we don't know where canine or first molar need to be placed. There's no anatomical reference lines. Of course, if you're a skilled operator, you will look at the canine guidance or the opposing teeth. But if you're not a very skilled operator, it will be very difficult. Then guided surgery would be very helpful. OneGuide system is excellent, but I don't think it will work every time. This is my actual case. When I start the digital guided system, I always superimpose the pre-op planning data with the post-op data, and I accumulated all such data to see the reliability of the data. In this case, the implant is buccally inclined, or they happen from time to time. So, in order to prevent such cases, what do we need to do? In order to do the guided surgery accurately, we need to do a lot of preparation before the surgery, and many things need to be considered during the surgery. As I began to do the digital guided surgery, I have analyzed the sources of the errors that can occur before the surgery and during the surgery. The first step of the digital guided surgery is the merging. The scanned data and the CT data are merged together. That is the first step of the digital guided surgery. If that goes wrong, everything will go wrong. Merging is the very first button that you have to button. If that goes wrong, the rest of the procedure may get wrong. So merging is the most important thing. Let's have a look at what merging is. As I talked about the workflow in the first lecture, the number one is merging. No matter how well the CT impression or intraoral scanning has been done, if you do the merging wrong, everything will go wrong. In order to do the merging properly, we need to take the CT data properly. There are two sorts of images. Which one is better? The middle one is not an accurate image. During the CT taking, the patient moved, therefore 2 millimeter or more blurring has occurred. If there are teeth in upper and lower jaws, a patient can bite down on a bite plate and control the lower jaw movement, but in the case of complete edentulous patient, or there is severe mobility in the remaining teeth in the upper or lower jaws, or the patient has a Parkinson's disease, they cannot control the movement of the lower jaw, so a blurring problem would occur. In that case, the merging would not be very good. Therefore, like you see on the right-hand side, with a clean cortical lining, you need to take a very clear CT. Before you send your guided surgery patient home, you need to check the quality of the image, and the image is severely blurred like this. You need to take the CT again. When the CT is taken, you need to check from the outside whether the patient is moving or not. And if you have a scanner in your office, you can use the scanner like a Trios, or you can take an impression. I prefer using the scanner. However, for complete edentulous patient or many implants need to be placed, and they will be immediately loaded with prefabricated prosthesis. In that case, I still prefer to use the impression taking. I prefer to use the model scanning, and this may be my own opinion. When we provide a complete arch treatment for complete edentulous patient, the conventional impression taking is better than or more accurate than the digital impression taking according to some research. Maybe I need to improve my skill, but for a complete edentulous patient, scanning is less accurate. Therefore, if it is a case where a prosthesis is prefabricated for immediate loading, I prefer impression taking. After good CT images are taken, impression is taken, or scanning is done properly, the two need to be merged. And merging is the most important thing. When we do the merging, outline of teeth images are superimposed. The teeth outline in the model from impression taking and the teeth outline on CT images need to be superimposed. If at least 3 or more teeth outlines can be superimposed, 3-dimensional merging, accurate merging can be made. But what about this? A complete edentulous patient, there's no teeth, there's no reference to use in the merging, there's no teeth. In this case, how can we do the merging? Teeth, which are the fixed reference points, do not exist. It is tricky to do the merging. So, the manufacturers of digital guided surgery provide different merging protocols. So let me explain briefly the merging protocol. The first such protocol was developed by the OneGuide for a complete edentulous patient, and it's called a double scan technique. If the patient has used well-fitting denture, the denture is replicated and the holes are made into the denture, and the gutta-percha, the radio-opaque markers are inserted. The patient wears that denture in the mouth, and the first CT is taken. After that, it is removed from the patient. In the place where the denture was, the replicated denture with the radio-opaque markers are put in, and only that will be filmed. After that, in the planning program, the two are merged by superimposing them. And this is the double scan technique. Now, it is hardly used because to use the technique, the patient has well-fitting denture. If not, we need to make the denture first. This cannot be done for immediate placement after the extraction. If the existing teeth have severe mobility, guided implant placement immediately after extraction is to be done. This cannot be done. Replicating or making a denture will incur lab cost and time. So today, this is not really used. Another company uses this type of approach. The ready-made radio-opaque markers in a disc shape are attached directly to gingiva. You cannot attach them directly with resin, cyanoacrylate, or histoacrylate like tissue glue is used for the attaching. It's not a bad approach. In the maxilla, they can be attached to the palate. What is important is when you attach the radio-opaque markers directly on gingiva, you should do that on the attached gingiva. That is to the fixed gingiva. If you attach them on mobile alveolar mucosa, positions will change when taking impressions or CT images. They are not fixed points, so cannot serve as reference points. On the maxilla, you can attach them on the palate. What about in the mandible in this type of patient? Due to severe alveolar bone recession, alveolar mucosa crept up to the alveolar crest. If it is maxilla, you can attach them, but what about using a guide in mandible? Nowhere to attach them. In this case, it is not possible to attach the radio-opaque markers with resin. So when I consulted on the Osstem OneGuide, on the method which was developed together as a protocol is the fixture scanning technique. In this complete edentulous patient, they can be attached with resin. But if that cannot be done, or even they are attached directly with resin can fall off while taking CT images or impressions. To solve the issue, the fixture scanning technique was devised. First, in this patient, Osstem ortho screws are used. 1.6 mm diameter and 4 to 6 mm length ortho screws are placed. Anesthesia needs to be used, so a little invasive, which is a disadvantage, but it can most definitely fixate the radio-opaque markers. 3 or 4 ortho screws are placed without additional drilling. As it has sharp apex, it can be easily inserted on top of the placed ortho screws, where wires will be connected. Radio-opaque markers are attached with a flowable resin. That means the metal of the ortho screw head is shielded for blurring and scattering, and the flowable resin playing a role of radio-opaque markers in the shape of teeth are attached. This is the case. On the maxilla, only rootless ones remain pre-op picture. In the lower anterior, there are teeth, so maybe okay, but what about the posterior region? Another problem in the anterior region is that the teeth are all restored with the PFM crowns. As I said before, if you take CT images due to light scattering of the metal, the outline of teeth cannot be accurately captured. So there are remaining teeth on the mandible, but I prefer to place ortho screws in the posterior region. 4 ortho screws are placed in the maxilla and 4 in the mandible. Without additional drilling, after giving anesthesia, they are placed. After that, the flowable resin is used to attach radio-opaque markers. After that, if you have intraoral scanner, scanning can be done, but in this case, impression was taken. The flowable resin part having the role of radio-opaque markers will be registered on the impression. When a model is made, the resin will be reproduced. The appearance of the resin will be like a teeth, and on CT images, the resin will appear like radio-opaque markers, so superimposition can be made on those. If you look at here, superimposing gingiva is not possible because it is pressed down during impression or CT taking, and clear outline of gingiva cannot be found on the CT. As you can see, color green means accurate merging is achieved without distortions. As you can see, based on the radio-opaque markers, that is the flowable resin, accurate merging is achieved. The same is true for the mandible. The radio-opaque markers, the resin, on the teeth and 4 ortho screws appear green, indicating accurate merging. Important things that we need to consider before surgery: restricting patient movement to take a good CT images, good impression taking, and most importantly, for accurate merging. In a completely dentulous patient or multiple teeth missing patient, the following should be considered. Next is the fabrication of guides. Guides are mostly printed with a 3D printer, so the quality is depending on the quality of the 3D printer. So Osstem adopts very high quality polyjet type 3D printer with the error range 0.05 millimeters, 50 micrometer, which is excellent. So compared to the DLP or SLA type 3D printers that have been used in the office, Osstem adopts very high level specification. So if you use Osstem OneGuide Center, you don't need to be worried about the accuracy of the printout. Up to now, we have looked at errors that can occur during the preparation or guide fabrication stages. Most errors are made by dentists during surgery, so let's look at how we can do the surgery, considerations, and technical tips. First, errors are made during the positioning of the guide. The gap between the inside of a guide and the supported tooth should be checked in terms of the fitting of a guide. There is a window through which the gap can be checked at the side of a natural tooth adjacent to the drilling hole. Through the guide, you need to check the fitting of a guide. As the easiness of insertion and removal is depending on the removal direction of an RPD, the gaps can be seen depending on the severity of crowding of adjacent teeth, the direction of insertion and removal. On the left-hand side, through the window, you can see the gap is severe. In this case, it is not properly positioned, so you need to change the direction of insertion and removal or control the undercut to make it sit as in the right before you drill. Even the merging is good and the guide is well made, if you drilled with improper positioning, a lot of errors can be made during the placement of an implant. We need to think about several things. There are many different types of a guide. Depending on how the guide is supported, there are three types. Tooth supported means it is supported by teeth. And if the support comes from teeth and mucosa, then it is called tooth and mucosa supported. If there's no teeth, it is completely mucosa supported. In this case, most of the support of the guide comes from the mucosa. Then it should cover a larger area of mucosa for easy positioning. So for impression taking and intraoral scanning, the border should be extended. That way, the guide border can be extended to the vestibule. So border extension should be made during impression taking and intraoral scanning. That way, the alveolar ridge, all of them can be covered and the guide border can be extended to the vestibule. Then this kind of guide can be made for easy positioning of the guide and the stability. Just as we extend the border of a denture to stabilize it in the mandible, border extension should be done like this. When you position a guide in maxilla or mandible after anesthesia injection, in most cases gingiva is bulged. If you press down the guide not so tightly, the guide will not be positioned fully. To prevent it, you need to fix the guide while pressing it down fully. For how long? Until the gingiva below is a little bleached. And you need to use anchor pins to fix it. It should be tightly adapted, and you need to check if there is no gaps between the inside of the guide and the gingiva. Then fix it and begin the drill for proper implant positioning. So up to now, we talked about the guide positioning. When it is supported by teeth, how it comes in contact with the adjacent tooth. That means that the gap between the inside of a guide and the adjacent tooth should be checked. When there is no teeth, you need to check if there is any gap between the guide and the gingiva. A lot of deviations can occur during drilling. The drill can slip or tilt. If drilling goes wrong, the implant goes down or follow the drilling path, implant will go wrong as well. So drilling is very important. So we should avoid tilting or slipping of a drill. You may think it's a common sense, but it's not always the case. This is my first guide case. As you can see, right side, no residual teeth, and there is a supporting teeth on the left will happen, just like a fish fin. The guide is fixed on the left, but on the right side, it will be tilting like a fish fin. There will be less tilting near the adjacent teeth, but more far from it. In this case, to augment the ridge between the implants, even a flap was raised. On the right side, there is no teeth, and even a flap is raised from the supporting gingiva, so the guide will have no support at all, flapping like a fish fin. Thus, the deviation, like in the slide you saw before, occurred. As I said before, depending on how the guide is supported, there are three types: tooth supported, tooth and mucosa supported, and mucosa supported. In the case of the tooth supported, the drilling can be made accurately on the mesial and distal side. teeth exist, mucosa below can be opened because the guide is supported by teeth. But what about this? Tooth and mucosa supported template. There's a residual teeth on the interior, but there's no teeth distal, free end distal. What happens? In this case, a lot of deviations can occur. There is support from the teeth in the anterior, but the guide will tilt in the posterior drilling. We tell you, when drilling through a guide hole, you need to drill to the full until a OneGuide drill stopper pressed down on the top of the guide. In the posterior, as there is no teeth, the mucosa is pressed down. Due to the gingiva tension, the guide is tilting distally, like this. So in most free-end cases, implants tend to tilt distally, like a fishtail effect. It will tilt distally. To prevent this, in the OneGuide kit, there are 3 anchor screws, an anchor drill, and an anchor driver to place the screws. In the OneGuide kit, they are here. The anchor drill is to place the anchor screws. And there are 3 anchor screws, as 3-dimensional stability can be obtained with the 3 screws in 3 locations. This is the anchor driver used for installation. In other companies' case, this anchor tool need to be purchased separately. So another advantage of the OneGuide kit is this is included in the kit, so this can be sufficient to be used in various cases, as they can be used as necessary for complete edentulous patients or a free-end case supported by both the tooth and mucosa. The anchor pins are used to fix the guide to prevent the guide from tilting or deviations. So 3 screws are used to fix the guide. Most of the guide's anchor screws are accessed laterally from the buccal or lingual side for easy access. In the maxilla and mandible, they are inserted laterally. But for vertical guide stability, additional anchor system or stopper is developed. That's the bone stopper developed for vertical fixation. Through the guide hole, it is directly inserted to prevent the guide hole's distal tilting. It looks like this. There's a screw at the bottom. On the top portion fits the guide hole so that it is preventing the guide hole from tilting distally. This is called the bone stopper. Another thing, after implant placement, this is connected to the implant to increase the stability of the guide. This is the fixture anchor for vertical fixation. No mount type implant is connected to the fixture anchor. After that, anchor driver is used to place it. So it is fixated first. Then when you drill the next hole and place the implant there, the distal guide tilting would be prevented. This provides additional vertical fixation. So if you use the additional tools in the kit, you will be able to accurately place the implant, and the prefabricated prosthesis can be connected. So this maximizes the accuracy. The bone stopper and fixture anchor are not included in the kit, and they need to be purchased separately. Up to now, we have discussed the big cases such as complete edentulous cases or multi-teeth missing cases like the free end and the tools to prevent the deviations of the drill. Another thing, when you place in the upper anterior single implants or 2 or 3 implants, especially immediate placement in the extraction socket, a guide can be tilted because if you think about the characteristics of the OneGuide, For the immediate placement in the upper interior, the side cutting drill is the most emphasized as important because for immediate placement in the upper interior for initial stability, indentation and expansion should be made on the palatal side of the socket to place an implant, but in the OneGuide kit there is no side cutting drill. This happens if you use the OneGuide drill or initial drill is used. It is okay if the apex of the initial drill in the kit makes an early contact on the palatal wall, but if an initial drill side wall which does not have a cutting blade touches the palatal wall, what will happen? It will be pushed, it will slip, leading to the guide tilting or even fracture. If the drill is not driven anymore and it is pushed, you need to realize that the initial drill side wall touches the palatal wall of the extraction socket at the upper interior, but there is no solution for it in the past. So we made an indentation on the palatal with the side cutting and tried the initial drill again, which was cumbersome. Just to do the guided surgery, we need to prepare the taper kit or side drill. To solve this, especially during the immediate placement in the canine, drill slip can occur as the palatal wall is hard. So we came up with the path drill. The path drill lengths have two options. It looks a little bit different. There are two types, two lengths, and depending on the template hole, we have two types. The guide barrel's diameters have two diameters, 5.0 and 5.7. When do we use the path drill? For the immediate placement in the upper anterior, if the side wall of an initial or OneGuide drill touches the palatal in the socket, the drill is pushed or does not do the cutting. When you feel excessive resistance or the drill does not advance, this path drill is used to make a deep indentation in the palatal, like this. After that, the OneGuide drill or initial drill can be tried. As the palatal interference is removed, you can advance the drill easily. The end is flat. It looks like a dedicated cutting drill. When the end makes a contact, strong cutting can be made and is designed to make a lattice shape. The lengths are 7 and 13 millimeters. In the previous lecture, one cast drill has 10 and 7 millimeter drills, and if you use the 10 millimeter first, the early contact cannot be made. The same is true for this. The early contact between the guide barrel and the guide hole cannot be made. Therefore, you need to use the 7 millimeter first. You need to respect the early contact. So 7 millimeter should be used first. The bone stopper, fixture anchor, and the path drill are not included in the OneGuide kit. Such accessories can be collected in this kit. So this is the OneGuide accessory kit. This needs to be purchased. Bone anchor, fixture anchor, and if you want to place SS or US, not only TS, you can include the mount drivers for those in this accessory kit. Depending on the surgeon's preference, the necessary items can be included in here. For myself, the flattening drill has multiple blades, and after the grinding of the cortical bone, the bone can stuck in the blade. It's hard to remove that bone, so I prepare some more flattening drills in this kit. If you believe 3 anchor screw rods are not enough, you can include more of those here. So depending on the surgeon's preference, the kit can be customized. Lastly, this is the sources of implant placement errors. So, if you need to place multiple implants on both sides, symmetrical from left to right in a complete edentulous patient, placing implants in a zigzag manner is recommended. Implants are usually tapered bodies, so the top portion is wider. Therefore, during depth control, torque can go high, and as palate and lingual wall is hard, making the implant tilt buccally. So, place one on the right and then one on the left in a zigzag fashion. If you place all on one side first, implants will a little tilt buccally, then the guide can have a little tilt as well, therefore zigzag manner. Another important thing, we have talked about the clinical tips. Operator's experience is very important. If you think guided surgery would give the same result, whether you are a beginner or a skilled operator, that is not the case according to many research papers. Even though the guided system is very good, if the operator doesn't have a displacement skill, various deviations or errors can occur. Therefore, the error rate depends on the skill level of an operator. Therefore, you need to master the basic courses of implant placement. Up to now, in the 5 lectures, I covered digital guided surgery, clinical applications in the upper and lower anteriors, sinus lifting, using crystal approach, multi-teeth missing cases, overcoming limitations, providing my clinical tips in the brief presentations. Lastly, let's have a look at some questions before we finish. How many ortho screws need to be placed? This is a frequently asked question. Where and how many do we need to place? Ortho screws are mostly placed flapless, so you need to avoid the anterior region and place them in the posterior where bone quality is good. At least 3 need to be placed for accurate 3-point merging. If a couple of them have a mobility and you are not comfortable, then 4 need to be placed to use the 3 best ones out of 4 for merging. People frequently ask how to remove the ortho screws attached with the resin. If you hold the resin firmly with a gripper, the resin will break easily, exposing the head of the screw, and reverse the driver used for installation. Then they will be easily removed. Or you can reverse rotate the gripper holding the resin. They will come out easily in maxilla, and in mandible, remove the resin on top of the screw first and use a driver to pull out. Not very difficult. Anesthesia is given for the placement, and patients do not really suffer when they are removed. So up to now, regarding the OneGuide, 5 lectures in a series have been provided. I wanted to help you through these lectures, and there's constraint of time, and this has been the online class. So I think I've not dealt with in-depth content. Osstem has various hands-on courses. You can learn more clinical tips. I hope my lectures have been helpful for you, especially in using the guide. Thank you.
감사합니다.